So welcome to this volume of the DVD presentation. This is going to cover the cervical and thoracic spine together. And as you'll see during the course of the assessment and treatment approaches used here, that they are quite intimately related. Just a few little words on background anatomy of relevance to these areas. Firstly, the cervical spine is unique in that it is a very mobile area. It's the most mobile area of the spine, and it has the ability to move independently, where the upper cervical spine can move independently of the lower cervical spine. The mobility of the cervical spine is due to a number of factors, including the size of the intervertebral discs and the shape of the facet joints, as well as other factors. As well as having mobility, it must have stability to support the weight of the head and the delicate structures such as the spinal cord. The thoracic spine is a more rigid structure. Again, this rigidity is produced by the shape of the vertebral bodies and the long spinous processes, the shape of the facet joints, and the rib attachments. And this rigidity is there for a reason, to support the delicate vital organs inside. So therefore, when we're looking at the cervical and thoracic spine, there is quite an intimate relationship with them as we move from the mobile cervical spine into the less mobile thoracic spine. We're now going to move on to the first part of the assessment of the cervico-thoracic region. And as always with other regions of the spine, this starts with postural assessment. Now, your postural assessment will depend on your subjective assessment. And if the patient complains of problems in sitting, then you are best to observe posture in a sitting position. However, if the subjective complaints are of postures related to standing, then observe posture in standing. You may want to do both. In this, we're just going to show the sitting assessment. And we're going to start off again looking at the assessment of the posture from behind. So I'm going to ask Dave to turn around to the back. In the assessment of posture, it is a good idea to perhaps observe the person in their normal resting posture before you actually correct it. So Dave, I'm going to ask you just to sit as you normally would, where you feel comfortable. And again, it would be important to establish if this is the way the person would sit during their normal everyday activities. So for example, if they had pain at work in the cervical or thoracic spine, to assess whether this is the way they normally sit. For Dave here, again, I have his feet resting on a step in front, again, just to give him a bit of stability, or alternatively, they could be resting on the floor. Just to demonstrate how posture between the cervical and thoracic spines are interlinked, what I'm going to do is just get you to slouch a little bit more. And as somebody, you can just, again, just come up tall. Okay, and just let yourself slouch, just let yourself relax, let yourself give in the middle. So as somebody goes into a thoracic flexion, their head will also change position. If I now, again, don't even think about the head, Dave, I just want you to sit up tall from the mid-back. And as we start to correct through the thoracic spine, the neck will automatically start to change position as well. So these are very interlinked, and it's quite important that when you're assessing posture of the cervical spine, that you must undress to the waist. And obviously for the thoracic spine, they must be undressed to the waist also. So some of the important things to look at from the assessment of the cervical spine would be the position of the head on the neck. Again, in looking at head position, we want to see if it looks rotated or not. And again, this can sometimes be apparent by how much of the face can be seen from the back. So that might indicate whether there's a rotation component to the posture asymmetry. We can also look at the levels of the ears, and again, to see if one is higher than another. This might indicate a side flexion asymmetry. And we can look at the position of the neck on the shoulders. Again, we can look to see if he had any kind of a shift, or again, if there was any side flexion further down into here. Again, from the back, we can look at the levels of the shoulders to see if they are level. And it is quite common for there to be a little bit of asymmetry between the shoulders. So it is quite common for one shoulder to be lower than the other. And this is often the dominant side. Again, if you find there's an asymmetry, it's important just to note it and to see if it'll then be relevant further on into your assessment. You can also look for any muscle bulk changes. So again, some of the muscles here would include the trapezius, supraspinatus, infraspinatus. These may be more relevant in the shoulder pathologies, but again, worth considering. We can also look at the mid-traps and lower traps bulk. And again, these can be interlinked with cervical and thoracic problems. We can look at the shape of the curve here, again coming from cervical into this cervico-thoracic junction and down into the thoracic spine. The cervico-thoracic junction is where the spinal curve changes from the cervical lordosis to the thoracic kyphosis. And again, due to the shape and the change of the vertebral bodies and the facet joints, this is a common stiff area. And again, you can observe here if there's a Bison's hump, which is a thickening or prominence of that cervico-thoracic area. Going down into the thoracic spine, again from the back profile, we can see if there is any form of a scoliosis or any form of a shift. Some of the landmarks to consider would be the spine of the scapula, which should be level with T3 or T4, and the inferior angle of the scapula, which should be level with T7, T8. So again, we can look at the scapular to see if they're abducted or adducted. We can also note the position of the lumbar curve. Again, we mustn't forget that the lumbar curve and thoracic curve are very intimately related. So again, observing if there is any asymmetry here, if there is any increase or decrease in the lordosis, or if there is any shift in the lumbar curve. If you detect a scoliosis, a change in a deviation in the vertebral spinal alignment here, again, it's important to establish if that is postural or structural. And this would be done in standing, where you would ask the person to flex forward in standing, and if the scoliosis disappears, it's postural, but if it remains, then it's structural. We're now going to move on to assess from the side. So again, you can stay in that same position there, Dave. So from the side, the type of things we're going to look at, again, will be the head on neck posture and the neck on trunk posture. So again, we want to look at whether or not the head, the upper cervical spine here, looks flexed or extended. So for example, if it was to look extended, we might see something like that. Okay, and again, if it was to look flexed, we might see something like that. Again, it would be important, if somebody has got changes around their upper cervical spine with their posture, ask them about whether they wear glasses or not, and does the posture maybe assess them with or without their glasses, because that might be a factor if, with regard to changes in their upper cervical spine. Again, we can look at the shape of the cervical lordosis, so we should have a mild cervical lordosis. If there was a loss of the lordosis, this would appear flatter, and this would indicate or may indicate muscle spasm. We can also look then at the lower cervical spine, and again, this is a common area where we see the forward head posture. And the forward head posture, I'm just going to demonstrate it here. If you just stick your chin out there for me, Dave. The forward head posture here tends to be associated with lower cervical flexion. Again, this can be quite a common postural abnormality. It would be important to decide if that is relevant or not to your presenting complaint. Coming down, then we can again look at this cervico-thoracic junction to see if that is prominent or not. And then coming down into the thoracic, we can have a good look at the thoracic curve from the side to establish whether or not the kyphosis is increased, decreased, or normal. If somebody had an increased thoracic kyphosis, they might commonly have a more rounded shoulder appearance, and they may also have a compensatory lumbar lordosis. If their thoracic curve appeared flat, this would be quite straight through here, and also the scapula would have the appearance of winging, so you would see what would appear to be very little muscle bulk there, but that is due to the shape of the curve. So it would be important to differentiate a flat thoracic spine from scapular winging. And we can also look at the shoulders, again, because the shoulder is very interlinked with the cervical spine. Again, many muscles attach from the cervical spine into the shoulder. We can assess the scapula and the shoulder position. We're now going to look at posture from the front. So I'm going to ask Dave to just turn around. And again, we can use the step as we did in looking from behind, or feet on the floor. So from the front, the things we want to look at again will be the head position with relation to the neck, and this should coincide with what you see from the back. Sometimes things can be more obvious in either the front or the back position. So again, we can look at whether the head is rotated or not, whether the head is side flexed or not through the ear levels,